Telebehavioral health offers tremendous potential to improve patient outcomes and expand access to quality care. It's estimated that 44 million adults in the United States have a behavioral health disorder, yet fewer than half of those people receive the care and treatment they need. In part 2 of this podcast on telebehavioral health, 3 physicians discuss how to implement a telebehavioral health program or strengthen an existing one, focusing on strategies to overcome challenges, measures, and reimbursement. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle, senior writer with AHA. In part 2, the conversation on telebehavioral health continues with Dr. Jay Bhatt, senior vice president and chief medical officer with AHA, Dr. Shantanu Agrawal, president and CEO of the National Quality Forum, and Dr. Arpan Waghray, executive medical director for behavioral medicine at Swedish Health Services in Seattle and chief medical officer for Wellbeing Trust.
Arpan, given your work in this area at Providence, one of the issues that surfaces in the conversations with health systems about telebehavioral health and really interventions that they're trying to design to address an issue is how long should health systems be engaged in this work before they see an impact? Could you talk about your perspective and experience on this?
What typically happens with most behavioral health services, telebehavioral health and otherwise, is that the outcome measure is cost avoidance. And so if that's what people are looking for, then, not before 3 to 5 years would you actually be in a position to start some clear way to demonstrate value. And so to answer your question, the way we started this work, so we have 51 emergency departments across our 7-state region, and we're sitting across there and looking at all the places that had no behavioral health services whatsoever, and then created a network over the last 2 years that now serves 34 of the hospitals that had absolutely no services. And this is not only rural critical access, but it was also LA and other places. Now, the return on investment is still the fee-for-service way of generating revenue, which is not sustainable. It took us about 2.5 years now to get to all these places. We're now showing a little bit on how we're impacting in some sites the length of stay and 7-day readmission for EDs, but it's not sufficient to make a strong financial case for it. So how do you build in other outcome measures? And I would say at least giving this 5 years if you're building a large-scale telehealth program to actually look at outcomes that are meaningful.
Let's go to the next issue I want to talk to both of you about. Implementing or sustaining telebehavioral health services may be challenging. We know that organizations are at different places in their journey and sophistication around this. Arpan, what are strategies for healthcare organizations as they implement telebehavioral health services or overcome any resistance to change that's needed to sustain a program or service related to this area?
Thanks, Jay. And this is a really important question. I think what Shantanu described is so essential. How does this fit into the existing workflows to optimize the experience and outcomes? Lessons that we've learned from many failures we've had is really taught us to start by taking a step back, very clearly defining the target population that you want to start implementing the program into, and engaging all the key stakeholders right from the very beginning. So say health system is thinking about addressing the challenge of emergency department boarding or behavioral health care in the emergency department, one that many of us face. You need to make sure that the ER doctors and nurses and social workers are engaged in the conversation right from the very beginning. But as you define the target population, you understand their workflows, the technology then seamlessly fits into that. I would also say that it's extremely important that there are little things that need to be thought of before you go ahead and go live with these programs. And that's why I found the manual that both of you referenced earlier to be extremely helpful. It goes into a lot of practical aspects of what health systems, without feeling overwhelmed, can start doing. Things like, if you're going to implement a program, you need to have a crisis plan. Say the technology fails or something happens. What is your strategy going to be so that people are not overwhelmed and one bad experience does not shut down the whole process? You also need to work on ways in which the therapeutic engagement is there. So we've gone out of our way to ensure that our providers are taught camera etiquette. They have, what kind of lighting do you need in the room? And similarly, the telepresenters on the site are trained to get the, appropriate informed consent from patients, prepare the patients for the clinical encounter, and then make sure that everything works seamlessly. And then the last thing over there would be to make sure that the right information exchange happens with the referring provider, and then the treatment plan is then executed. So there's several things that need to happen, but I think if the health systems that are starting to do on this journey define the populations they want to start with, they can easily start building around that.
Excellent. Those are practical approaches to engage in these challenges and overcome them. Now, Shantanu, from your work with NQF and those that are involved in the field on this issue, are there examples that you can share about how some of the barriers are being overcome or challenges being addressed?
I think Arpan's description is just so right on. It's very real world and I think clearly experience-based. What we have seen amongst our members and stakeholders that are ultimately really successful is that they start with small-scale pilots. They develop an understanding of what a use case is and really work through that. That allows them to deal with the very tactical issues that Arpan laid out, those and others. I also think there is a value to patients that these technologies can produce, but I also believe that clinicians need to feel some kind of value from them as well in order to be bought in. So again, this is why it's very key not just to have this hanging out, somehow adjacent to the clinical workflow. I think clinicians need to feel like they're getting value from it. One real area of value that we've seen is clinicians being able to use these technologies to communicate with their peers. So in environments that, for example, might not have access to the specialist services that they're looking for, this is a great way to get specialist input and, almost, get that advice that you're looking for that might otherwise not be available. We've seen good use of that in, for example, the VA, and I think there are rural communities that are doing it as well. Your point earlier, Jay, about payment models needing to follow the technology appropriately, I think is absolutely right. Payment should not be a barrier so that these technologies really get adopted and implemented. But I think beyond then small-scale pilots, you build on what works, and we've now seen health systems that have really taken virtual care quite far, right? So there's health systems that have incorporated it into primary care, specialty care, emergency care. They're using it for clinician to patient interactions, peer-to-peer interactions. And they're even using it to support things like intensive care services, right? So they're getting the intensivist in a virtual setting so that their clinicians in the ICU feel supported. So the technology can go quite far, but again, I think it needs to all be based on use cases and solving the needs of patients in your community.
Great, and that point about community is important too. I think that collaborating with community leaders or advocates to build trust is critically important, as well as thinking about what is the awareness of community partners around the telebehavioral health services your hospital or health system offers and the way patients and caregivers can access them. Shantanu, one of the things you talked about was sort of measures, and when we think about measures, and certainly the work that NQF is involved in, when it comes to behavioral health, what are measures that are meaningful and make sense for organizations to consider as they're trying to address their behavioral health challenges? And if they're particularly using telehealth as one of the approaches to do that.
We put out a measurement report now over a year ago, really trying to better understand what kinds of measures are needed for the telehealth environment. So there's a broad report that I'd encourage your listeners to access off our website. I think in the case of a particular use like telebehavioral, again, if it's tied to a strategy, a particular end goal, and I think oftentimes that is assessing or addressing access, I think there have to be clear access measures that are really focused on the needs that you're trying to solve for. So if it's a rural access issue, then you have rural access measures. If it's urban, if it's time to service or time after that first urgent acute crisis, whatever it is, the specific access issue that is trying to be addressed, I think you've got to have measures around that. Number one. I think number two, patient experience is really critical in this to ensure long-term buy-in, and as you pointed out, Jay, the buy-in of community resources. So I do think it's really important to assess the experience that patients and caregivers are having with the telehealth services, and again, to make sure that it's viewed very positively or that deficiencies are being addressed. And then number 3 is you've got to assess clinical outcomes. And in that sense, telehealth is no different from the traditional in-person clinical encounter, right? It should be the same clinical outcomes that are used to assess the in-person encounter, because I don't think there's any good reason to hold telehealth to a different standard, either higher or lower, right? So if the goal is managing a chronic illness, then there need to be clinical outcome measures that really look at disease management, chronic illness management, behavioral health management to ensure that the telehealth services are working. And again, they're working at least as well as the traditional clinical encounter. Right, so those are, I think, the 3 broad buckets of measures. Each has to be designed according to the specific program, the specific implementation approach, but certainly I see the need of all of those areas hanging together in a real balanced scorecard.
Earlier we talked about telebehavioral health services that are covered and reimbursed. Payment and coverage for behavioral health and psychiatry health services are a bit inconsistent across health plans in the state. Certainly we know earlier this year Medicare now reimburses for a number of telehealth services focused on behavioral health, including screening, behavioral counseling, and psychotherapy. How do you think about the approach to coverage and reimbursement based on your experience? And Shantanu, why don't we start with you?
Sure, Jay. This is obviously really critical areas. First, at first blush, I think what's really important is to expand coverage. And as you pointed out, that is definitely occurring both in the public and private sectors. In my opinion, I think what will really drive implementation and appropriate use of telehealth services is to not take kind of a traditional fee-for-service approach to it. I think that's challenging, and it actually makes it difficult to use telehealth services if, for example, the approach to medical record documentation is going to look identical to the in-person encounter, right? Some of the uses of telebehavioral, as we discussed earlier, are because, it is a cognitive profession. It's based on real discussion with the patient and involves less the physical exam. So we have to recognize that in the payment system and not hold it to an approach that will actually undermine or undercut the utility of the telehealth service. In my opinion, again, I think the most useful approach is one that really embeds telehealth services in population-based approaches and therefore a population-based payment model. That way we know we are using telehealth in highly efficient ways. It's not just sort of additive, but that it actually is improving the experience that patients have and potentially even the outcomes that patients are experiencing, and that's really integrated with a broader strategic approach. So I think population-based approaches that allow telehealth services to be implemented ultimately will prove the ROI that we're all looking to see in this area.
Arpan, what's your view on this issue?
I think Shantanu is absolutely spot on. The one thing, just very practically, that I would add, as we've gone through this journey, you pointed out that Medicare does reimburse for these services. However, it's limited to health professional shortage areas, and there's a lot of variability in the way commercial payers, especially the carve-out programs, pay for them. I think it's just important to recognize that. One place where we've run into some challenges and suggestion that the listeners might find helpful was the importance of using the HRSA telehealth eligibility analyzer tool. It's a mouthful over there, but it's an extremely valuable tool to determine if the originating site will be considered an eligible location for Medicare. When we started our work, we ran across multiple regions where they were inaccurately assessing whether we would be reimbursed, and that completely derailed the finances of the program. So I think it would be extremely helpful to do the best we can, but I think Shantanu is spot on that the fee-for-service way of thinking will only get us so far. Of course, we want to make sure that we're appropriately getting reimbursed for every service we're providing, and thinking about some of these practical things from the start of the program might be helpful.
Yeah, those are wonderful points to add on, and I think as we think about it from a comprehensive, holistic view, I think payment and delivery models also supporting resources for organizational training to address the stigma of mental illness, but also the approach to screening, referring, navigating to community and social services as part of the needs that patients may have, and then ensuring that patients and caregivers are supported in making progress improving their health in this area. Earlier in the conversation, we talked about the role of community partners, and we know that that's critical to ensuring the pathway to success for patients with behavioral health conditions. And given Providence's work in this area, I want to start with you, Arpan. What role do community partners play in your organization as it relates to behavioral health?
One of the most important things that we can do is be our community's partner in health. And there are several things that we're looking at. We don't need to build the services that exist in other parts of our community. What we need to do is seamlessly integrate our services and care. So how do we bring behavioral mental health care and services to everyone in need in our communities? Now, as we think about this for telehealth and telebehavioral health, one example comes to mind. We set up a telehealth program in a small rural community in eastern Washington where there are about 2,000 people who live there. And this program we set up in the emergency department because there was no access to care. What we learned is there are a lot of resources that exist there, and they're mostly through the faith-based community, and trying to understand how do we bring them into this program. And we started that work. We met with people, and then that has become a very successful program because everything is seamlessly integrated. And what I found really interesting over there is the same physician who cared for people in the emergency department is also the one who has one of the largest primary care practices over there, essentially cares for people in his clinic as well. And when we met with him and went through the establishment of this program, what we realized is that many patients might not have an opportunity to ever see a board-certified psychiatrist despite their needs. So he has to manage everything with whatever he's able to. So when we integrated this program, we made sure that every opportunity we had, we were doing the best we could. So case we remember seeing in the emergency department, our psychiatrist went ahead, did a careful assessment, but then provided recommendations that we then shared back with the clinic to ensure to start off with doing certain things. And then if this doesn't work, you can go to plan B and plan C. So that way the outcomes are better. But then that in the context of other resources that are also there in the community and making sure that everything is integrated.
I think that we're seeing more and more of the important role that community partners play in this work. Shantanu, when we worked together on the playbook around telebehavioral health, one of the success factors that was identified was community partnerships. And I know that this is something our stakeholder of experts and that were involved lifted up as really important towards the success of a telebehavioral health program. What's your insights and your view around some of the learning that you've had among your members on this issue of community partnerships?
Arpan has really laid out a great case study for the utility and importance of community partnerships. And look, let's be honest, community partnerships are useful no matter what the healthcare modality is, right? And in some respects, I think it's interesting that discussing a technology makes us think perhaps more about community partnerships. That may not always need to be the case. But, what certainly came up in the discussions, Jay, and building the playbook, part of meeting patients where they are, having that no wrong door approach that Arpan talked about, is also identifying community points of access. So are there places in your community that patients are naturally convening anyway, and utilizing those as ways of rolling out more patient training and education? Perhaps that's the location for telehealth services, again, if you can solve the privacy issues, et cetera. But I think it's a great access point for getting the patient and communities into the right clinical service. Collaborating with community partners to raise awareness. Somebody earlier on the podcast talked about the stigma issues and how to raise awareness around that, for example, in telebehavioral, really critical. And then maybe even using social media platforms, right, as another community engagement tool. As long as we're rolling out technology and really thinking about how to incorporate technology in our broader care delivery work, then we ought to be using things like social media platforms, because clearly communities and patients are on them, and they can be great sources of information to ensure that everyone is aware of what services are being offered and how to really take advantage of them. So partnering with the community is really critical. We haven't even talked about the issue of social determinants, but that's a whole topic that demands community integration and working with the community. So I'm glad we've sort of scratched the surface on this. It's an important topic.
Thank you so much. And I agree that work around social needs, social determinants of health, and health equity are really critical to help the field engage in and support behavioral health and a host of other conditions and environments, from chronic conditions to keeping people healthy where they're at in their communities. And I think we've seen also on community health needs assessments, behavioral health be a critical area of need. And one of the approaches some organizations and communities are taking is the notion of community visioning, where hospitals and health systems are a guest at the community's table. And so I think in this conversation, you've also alluded to that fact that there's co-production that needs to happen in order to design for success and meeting the needs of people in that community. So I think we're coming to an end here and want to just wrap this up, but want to say thank you to both of you for your great insights, your perspective, and your leadership on this issue. You're really helping the field make progress both in your markets and across the country, and so thanks so much for sharing your expertise. With the impact of behavioral health disorders in the United States, telebehavioral health offers a tested solution to provide patients with timely and convenient access. It increases a hospital or health system's capacity to deliver high-quality behavioral health services. Now, telebehavioral health can be as effective as in-person care, and more people want to use technology to access healthcare services. The strategies we've discussed today are outlined in Redesigning Care, a guide developed and published by the AHA Center for Health Innovation and the National Quality Forum. I encourage you to visit aha.org/center/TBH-guide. There you'll find more information to help your organization implement, strengthen, or sustain telebehavioral health services. Thanks again to Dr. Shantanu Agrawal and Dr. Arpan Waghray for joining me today. Really appreciate both of you for your comments and work on this issue.
Thanks, Jay.
Thank you, Jay.